Good morning, everyone. We are now on our second of a series of webinars in close collaboration with the Department of Health and the Philippine College of Physicians. We had our first webinar last May 6 on the topic General Principles of COVID-19 Response. And for our session today, we have a very interesting and relevant topic, COVID-19 testing in the Philippines. Where are we heading? For this particular session, our general objective is to recommend the appropriate diagnostic tests for Filipinos affected with COVID-19. Specifically, we will provide the situationer on current testing capacity and testing guidelines in the Philippines. We will enumerate the tests available globally for COVID-19. We will differentiate the tests available in the Philippines based on sensitivity, specificity, predictive value, and other parameters. We will differentiate the pros and cons of mass testing versus expanded testing, and we will recommend testing strategies and appropriate diagnostic screening for Filipinos and enumerate the future directions and targets related to testing in the country. I am your moderator for this webinar. I am Dr. Nemencio Nicodemus Jr., a regent of the Philippine College of Physicians. Our first speaker for this morning's webinar is none other than the current OIC Undersecretary of Health and previously the Assistant Secretary in charge of Public Health Services team. Of course, we all know her as having served as the Director of Health Facilities and Services of the Regulatory Bureau and the Chief of the Health Research Division of the Health Policy Development and Planning Bureau. She is, of course, none other than Dr. Maria Rosario Vergere. Our second speaker is also known to us because he has always been an uninvited speaker, particularly in the area of infectious disease. He is currently a clinical associate professor of the Department of Medicine, Division of Infectious Diseases at the University of the Philippines College of Medicine and Philippine General Hospital. He is also the director of the National Institute of Molecular Biology and Biotechnology of the National Institutes of Health at the University of the Philippines, Manila. Our second speaker will be Dr. Edsel Maurice Salvania. And our third speaker for this morning is our current Director General of the Food and Drug Administration. He is a graduate of the University of the Philippines College of Medicine, and he, of course, as we know, is a former Undersecretary of the Department of Health. Our third speaker for this morning is Dr. Rolando Enrique Domingo. Now we call on our first speaker to start this morning's webinar. Good morning, Dr. Vergere.
Good morning to all of you. Good morning, Dr. Nicodemus. Maraming salamat po uli sa pag-imbita sa amin dito sa inyong webinar for the Philippine College of Physicians. We thank PCP for all the support and the expertise that you contribute to this COVID-19 response that we have for government. So ngayon pong araw na ito, mag-uusap tayo tungkol sa ating testing capacity, tungkol po sa ating testing dito sa Pilipinas. And I think later on, my presentation will be supplemented by, of course, our Undersecretary Eric Domingo and, of course, Dr. Edsel Salvania, our member of our technical advisory group. Also, we have, I think, Dr. Ana Ong Lim, who is also here with us to maybe later answer questions from our members of the PCP. Vince, may I have my presentation, please? So ngayong araw po ay ipapakita ho natin the COVID-19 testing here in the country. Next slide, please. So the outline of my presentation, dalawang bagay lang po, the strategies in scaling up testing and of course the expanded testing that everybody's talking about right now, which for many is mass testing. Next, please. So just to show you our priorities, the strategies that we prioritize, we have here an inverted triangle where the base is at the top, and the widest base that we have would be for prevention. And alam po natin lahat that we really are focusing on the preventive aspect of how we can prevent and control ito pong ginagawa natin no, against COVID-19. And this would be our measures of prevention na alam na po natin lahat. Pangalawa po, we would like to trace and monitor for symptoms. So we'd like to identify all of our contacts, and we like to identify, of course, our exposed individuals, monitor them for symptoms, and once we have done this tracing and monitoring, we'll be able to isolate and do quarantining. While we do that, we also do the testing, which is the fourth step or the fourth strategy that we have is to test so that we can effectively isolate and manage cases. Next, please. So ipapakita lang ho ng slide na ito ang aming milestones. Nag-umpisa po tayo dito sa ating response with COVID-19 by just having one laboratory for testing COVID-19. And this is our Research Institute for Tropical Medicine, which is also our National Reference Laboratory. When we started off last January 2020, we only had about 300 per day tests that are being done, no? That were being done. So 300 lang po ang nagagawa natin test dahil iisa lang po ang ating laboratorio. Pero nung nakita na ho natin na pataas na ho ng pataas ang kaso natin at nakita na rin ho natin no, based from experts' assumptions and analysis na we will be continuing no, to have these cases, the number of cases, government has decided to mobilize our subnational laboratories. So on the first half of March of 2020, we were able to mobilize 4 of our subnational laboratories, which were Baguio Gen, San Lazaro, Vicente Soto in Region 7, and Southern Philippines in Region 11. And then looking at our situation then and seeing that we still need additional capacity, we then again mobilized additional 3 subnational laboratories, which were Lung Center of the Philippines, the Bicol Regional Diagnostic and Reference Laboratory in Region 5, and the Western Visayas Medical Center in Region 6. By the end of March, we are seeing that a lot of tests has not been able to be processed on time. So we thought it best to ramp up the capacity, license more laboratories. And to date, we already have 24 licensed laboratories of DOH, 14 of which are government, 9 are private and NGO laboratories, and also we already have gene expert laboratories. Next, please. So the overall objective of our testing strategy is to achieve a national testing capacity of 30,000 tests per day by May 30 of 2020. This is not just government to work on this 30,000 tests per day, but this is through the collective response of both government and private sector partners. So I think all of you are aware already of this task force T3, whereby both government and both public and private are working towards attaining this 30,000 tests per day, private providing support through logistical support, through technical assistance, and also providing us with day-to-day guidance in how we do and achieve this 30,000 tests per day by the end of this month. Initially, we had a goal no, or an objective of reaching 8,000 tests per day because based on the numbers that we've had before, this was the numbers that our experts have mentioned to be appropriate so that we can detect all those needing tests. But as the numbers grew and as the numbers increased, it came to that point where our experts now are estimating that we would need around 28,000 tests per day in order for us to cover really all those who are needing tests in the country. Next, please. So with this objective, we have four major strategies to scale up our testing capacity. First is maximizing or optimizing capacity of our existing independent subnational laboratories. Next would be to license more subnational laboratories towards independent testing. The third is establishing big testing centers like pop-up labs, and also this huge center in Pampanga that we now have, and it's going to open on Saturday in strategic areas around the country. And the last one would be other testing approaches for continuing expansion. And best example for this and what we are doing right now is the Gene Expert Laboratory Testing Facilities. Next, please. So maximizing capacity of existing independent subnational laboratories, what we did at the start was to map out all of these existing subnational laboratories, looking at their inventories, looking at the number of machines that they have, looking at the number of health human resources that they have, and also trying to estimate how much per machine can be produced and how much human resources would we need for each machine to operate on a 16 to 24 hours testing process per day. So we were able to get the initial, the current capacity and the maximum capacity of each laboratory if we were to optimize their capacities, no, for these existing independent subnational laboratories. So what we did, we had to optimize their operations. Most of these laboratories at the outset only operated for about 8 hours per day. So we said if we added more machines, if we added or augmented their health human resources, we will be able to extend operating hours to 16 to 24 hours. And that is what we did. We added machines in our existing subnational laboratories. We were able to get support from the Department of Science and Technology, where they were able to loan us with different RT-PCR machines, also loaning us with biosafety cabinets. Also, Food and Drug Administration helped us with these biosafety cabinets. The others, we were able to get donations or support coming from our private sector, providing also automated extraction machines. So with that, we were able to extend the capacity of each of these existing subnational laboratories and for them to achieve their maximum capacity per day. Also, we got help from from the University of the Philippines Molecular Biology Unit. They were the ones who augmented the personnel of these existing subnational laboratories in order for them to operate into these 16 to 24 hours a day. Please. Next, please. This is the list of our private laboratories also. So just showing you the different laboratories that we now have. And with this kind of estimations, the maximum capacity per day was computed. And out of all of these existing subnational laboratories, we already can attain about 13,115 tests per day. Next, please. So this is just to give you the different accomplishments for our tests per day that we do. We already are able to test about, this is 130,000 plus unique individuals that had been tested here in the country since we started testing. About 90% of these are negative, and our positivity rate at this time is about 10%. There were also equivocal and invalid results which we had to do repeat testing. If we find this graph, we look at this graph and we see from April 6 until May 6, the number of tests that is being done per day. So if you would see, it's kind of erratic. It's not stable. This is because of the different issues that are confronted by our laboratories with their day-to-day operations. We will not hide it. We are having a hard time really with the sustainability of supplies in our different laboratories. That's why every now and then you will hear that one of our laboratories has scaled down its operations because of this supply factor or this issue in supplies. and the provision of which we are trying to partner with our private sector and of course our national government agency so that we can be able to access and source out more supplies and sustainable supplies for all of our laboratories. Yesterday, we had a total of 4,661 tests done on that specific day. The day before yesterday, we had a 7,130 tests done per day. So why is it that we suddenly had this decrease? It was because of the scaling down of operations of the Lung Center of the Philippines because as I've said, we are having problems in our supplies. Next, please. So the second strategy would be to license more laboratories towards independent testing. Currently, we already have 23 licensed RT-PCR laboratories, and we have pending applications, about 61 of them. If you try to look at this, I would want to emphasize on these different stages of licensing a laboratory because a lot of people are criticizing the Department of Health simply because they are saying that we are taking a lot of time in licensing laboratories. But I think us in the medical community, we understand how risky these processes of testing for COVID is. That's why we do not like to compromise the quality and the safety of the processes so that we can be able to produce results which are accurate, and also we are able to have a safe environment for our laboratories as well as the community. So we have 5 stages in our licensing process. The first stage is self-assessment. This is where the different laboratories would be sending us their intent to have a laboratory, and in turn we send them the self-assessment tool that we have so that they can already check if they have already the different requirements no for a biosafety lab level 2. That is our basic requirement. There should be this BSL2 for them to be able to eligible for this self-assessment. The second stage should be once they have returned to us their self-assessment, we will then visit their facilities. The visit will be done by DOH and our ITM, and also WHO is part of our team. We then try to assess and evaluate the requirements that they should have in their different laboratories. And once we are done with the assessment, we give them the number of deficiencies or whatever they still need to comply for them to go into the next stage of the processing of license. So the stage 3 really is compliance. And after they have complied with everything, we now go to the stage of proficiency testing, where there is a panel sent to them by our ITM. This is a blinded panel where they have to do hands-on application of really doing the test in their specific laboratories. And they have to get 100% in this proficiency testing, meaning they will get all the answers right for this test in proficiency. Once they get their passing score in this proficiency testing, they now can be certified by our ITM and licensed by DOH. So the last stage would be the licensing of the Department of Health for this laboratory. So you'd find in these different stages that really the ball is with the laboratory. If they can comply fast, and then we can license fast. We now facilitate and expedite this process actually. We have removed the different minor things that we ask for so that we can just expedite the licensing of laboratories. So with this, we already have 10 for self-assessment. There are 5 yet to be visited by DOH. We have 32 facilities under compliance. So they are still complying with different requirements. We have 4 laboratories who are now doing their proficiency testing, and we already have 23 licensed laboratories. Next, please. So these are the different laboratories that we have currently. These are the 23 laboratories that we have, and we can see that a lot of these laboratories are in the National Capital Region. Owing to that fact, that dito naman talaga po nag-umpisa no, yung mga numero ng kaso, kaya talagang nagkaroon po ng initiative and pagpupursige ang ating mga laboratorio na magkaroon talaga dito sa ating National Capital Region. We have one in CAR, which is the Baguio General Hospital. We have one in Bicol, which is the Region 5 laboratory. We have one in Western Visayas, the Western Visayas Medical Center. We have two in Central Visayas. This is Vicente Soto Memorial Medical Center and the Cebu TB Reference Laboratory. And we have one in Davao. This is the SPMC in Davao. So a total of 23. We already have mapped out the country as to access to these laboratories, and we have identified priority areas based on the number of cases and of course based on the access to these laboratories. And we have identified regions 2, region 3, region 4A, region 7, region 8, region 9, region 10, and region 12 and Caraga as our priority areas for this time. And we will be trying to fast track the licensing of all the laboratories that have applied and that are in our list in these different areas. And we are looking at 2 weeks as the target for us to be able to license these laboratories in these priority areas. Next, please. So these just are the stage 3 to 4 laboratories. So you'd find that we still have laboratories that are undergoing proficiency testing at stage 4, Asian Hospital, DLSU, and Allegiant Regional Care Hospital. We have a number for stage 3. Stage 3 is the compliance stage where they are trying to comply with the different requirements. So if you try to look at these areas would be these stage 3 facilities would be prioritized. We will be assigning specific teams so that we can provide technical assistance and we can hasten the process of their compliance so that we can be able to license in the next 2 weeks. So we have 13 in Luzon, 6 in Visayas, 9 in Mindanao, and another 7 here in the National Capital Region. Next, please. Our third strategy would be to establish big testing centers and pop-up labs in strategic areas around the country. You'd find pictures here of the JB Lingad big testing center that we have and will open on Saturday and will start operations by Monday. So pag tinignan ho natin, this is a big or a huge testing center, and this is through the help of Asian Development Bank, not just ADB. We also have our private partners which have provided assistance as well, like Unilab, in order for us to make this laboratory possible. So this laboratory is promising to provide 3,000 tests per day. So they will be able to start operations by Monday of next week. They are now undergoing their proficiency testing, and hopefully as soon as they pass this proficiency testing, we will be able to license the laboratory and operations would start immediately. So we also have pop-up laboratories, which is also part of the assistance being provided by our private sector. They now have 6 laboratories under construction for these modular laboratories, and we will be placing them in strategic areas of the country as extension of our subnational laboratories or a standalone laboratory in areas which are hard to reach. And there are still also a lot of initiatives that our private sector is proposing to us, and it is going to be part of this third strategy that we have. Next, please. So yung Task Force T3, this is what I had been telling you. This is headed by Sir Vince Dizon, which is the Deputy Chief Implementer that has been designated by the President of the Philippines. And in this task force, we have the big corporations here in the country, like Ayala Group, the Unilab Group, Zwillig Group, and all of these different sectors in the private sector, different groups in the private sector who are helping us in all of the things, even in our operational issues, the daily operational issues. So they have identified most urgent requirements that our laboratories are needing for this time, and they are providing it to us. And also, they are trying to identify priority hotspots where they can still provide augmented laboratories like these modular laboratories. So, ito lang pong table na to ay pinapakita lang ho yung testing capacity na gusto nating marating, no? And also, of course, versus the projected infected cases. Next, please. So the fourth strategy is the other testing approaches. So the other testing approaches for continuing expansion, you all know that we have these gene experts. And these gene experts uh, is something that would really provide us with this additional capacity for laboratory. Unfortunately, we like to temper the expectations of a lot of people because the supplies for the cartridges of these gene experts are not certain at this point. Because as we all know, there is this shortage of supplies where the manufacturer had already allotted a certain number for each country all over the world. And right now, after these initial deliveries of 15,000 in the country, there is still no confirmation as to when the next cartridges will arrive. The 15,000 have arrived here in the Philippines in tranches for these previous days that we've had. And we have identified areas that we will be providing for these gene experts. So what were the basis in us identifying these different facilities? We wanted to supplement the RT-PCR machines that we have. And we have identified areas where there are no access to RT-PCR machines. And also these areas also have high number of cases. So for the National Capital Region, of course, we have provided for the RITM and the Lung Center of the Philippines specifically because they are having a hard time right now with the supplies for the RT-PCR. So in order for them to continue operations, we have provided them with these gene expert cartridges so that they can continue with their operations. We have identified Dr. Jose N. Rodriguez Memorial Hospital specifically because this is a referral hospital for COVID of DOH, and also it can cater to that area of Caloocan and the other areas in which are contiguous and near the hospital. So they can lessen the burden of the lung center of the Philippines. Among Rodriguez Memorial Center, which is situated in Marikina, was identified because they will be able to cater to the Rizal province. The province of Rizal has a huge population, and all of this population, no, so this is being catered currently by the Lung Center of the Philippines. So in order for us, again, to lessen the burden of Lung Center of the Philippines, we are now supplementing it with another facility to use gene experts so that they can somehow lessen the load of Lung Center and also will be able to focus more on the Rizal province. We have provided for Region 1 Medical Center. They do not have access in Region 1 and they are part of the ECQ currently. Cagayan Valley, we all know that access is really hard in these areas. Jose B. Lingad was again given and provided as well as Bataan General Hospital because the Region 3 has a lot of cases and this is a very big area. That's why we have provided for them. Region 4A to support the rest of Calabarzon, owing to the fact that we still do not have any RT-PCR laboratory testing centers that are licensed in Region 4A. And of course, we provided for Region 4B, Hospital ng Palawan, because we know that they have to have access since they are island areas. Region 8, because they still do not have RT-PCR and there are also cases there. Region 9 was the very first that we sent gene expert cartridges to, the Zamboanga City Medical Center, because we all know now that there are clustering of cases in their jails, and we would like that the testing be started immediately in that area. Region 10 was provided, this is Cagayan de Oro, and Region 12, so that we can somehow ease the load of the SPMC doing the RT-PCR and also can provide more access to our our citizens in the Mindanao area. Next, please. So these are the gene expert laboratories that we have. So we still have pending certification and licensing of these 8 laboratories, but we are expediting them. Our target is to finish everything over the weekend so that by Monday, all of these laboratories that we have identified should be able to start their operations. The processing for these gene expert laboratories is much more simpler than that of an RT-PCR laboratory. Of course, we still need a BSL level, biosafety lab level 2, but the different, we just need to have them undergo the competency assessment after this, and once they pass that, we already license them. Next, please. So these are the certification status of the different laboratories we have identified. And as I've said, those facilities that we have identified a while ago, we are already expediting so that they can have their license the soonest possible time. Next, please. So the next one would be the expanded testing for COVID-19. So we have heard of this expanded testing, and a lot of people are saying that we should do mass testing. So we'd like to present to all of you our protocols for expanded testing. Next, please. So when we talk about expanded testing, we are not talking about mass testing everybody, all the 100 plus million population of the Philippines. It is not testing all individuals, but we only test those who are at risk of COVID-19 infection. When we talk about expanded testing, we also are not talking about indiscriminate testing. As I've said, I go back to this principle and to this guideline. We only test those who are at risk of COVID-19 infection. Next, please. So this slide, I have shown this to all of you last Wednesday. Again, I will reiterate because this is our priority list for the expanded testing. As I have mentioned to all of you last Wednesday, we have 4 subgroups of individuals in our classification for our prioritization list. And this would be subgroup A, who are the patients or healthcare workers with severe or critical symptoms and with relevant history of travel or exposure. The subgroup B, who are the patients or healthcare workers with mild symptoms, with relevant history of travel and contact, and also our vulnerable groups, who are the elderlies, the high-risk pregnant women, and those with pre-existing conditions. For subgroup C, these are the patients or health workers with mild symptoms but with relevant history of travel and contact. And we said in our protocol that we will start testing the subgroup C as soon as our capacity for testing reaches 8,000. And then our subgroup D would be the asymptomatics. These are our persons under monitoring. And we said in our protocol that we will start testing them once our capacity for testing reaches more than 8,000. So you'd find here in this table, again, exposure and symptoms as part of the variables. So for the first row, we'd find the high priority individuals, wherein we like to emphasize the subgroups A and B. We have already started testing them since the start. We are just now expanding to subgroup C and D. But we can only expand once our capacity reaches to this certain level. This is going to be progressive, this expanded testing. So for now, we are already including subgroup C in our high priority. So those with mild symptoms, but with relevant history of travel and contact. And then we have our low priority, those without symptoms, the subgroup D. It doesn't mean that when they are part of the low priority that we wouldn't be managing them anymore. We are trying to emphasize right now that even without testing, once you identify a person with symptoms, you immediately isolate them, as well as for those people without symptoms but are direct contacts of our suspects, of our probable and our confirmed cases. So our clinicians or our healthcare workers should not wait for the results of the test before they do action, should not wait before the individual is tested before they do action. once they are able to identify patients or individuals with symptoms or those without symptoms but are direct contacts, they should immediately isolate these individuals. Next, please. So for expanded testing for COVID-19, we would just like to put emphasis on this different information about the rapid diagnostic test. Okay, the rapid antibody test should not be used as a standalone test to definitely diagnose or rule out COVID-19. So alam na po natin lahat ito because clinicians naman po kayo at saka ito naman po ay basic knowledge na natin lahat na ang ating rapid diagnostic test or rapid antibody test should not be used alone and it should be validated. Kung ano man pong resulta na makuha nyo sa rapid antibody test, especially the IgM positives, should be validated by the RT-PCR-based testing. Hindi po natin siya pwede gamitin na diagnostic tool para sa ating COVID-19. The second would be, yun nga sinasabi natin, validated po siya ng RT-PCR test or the RT-PCR laboratory testing center. So kailangan kung gagamit tayo nito, alam natin kung saan tayo magpapadala ng ating validation or for confirmation itong mga resultang makikita natin sa rapid antibody test. Ang pangatlo po, yun pong sinasabi kasi natin na maaari po natin gamitin sa mga recovering cases ang rapid antibody test. So, yun pong mga nasa ospital natin ng mga pasyente na wala na pong mga simptomas, clinically stable, and has been cleared by their physicians already can be subjected with this rapid antibody test. And pag nakakuha po tayo ng test dito like IgG, kailangan pa rin pong i-validate with RT-PCR but they can already be discharged based on this rapid antibody test. And yun lang pong rapid antibody-based test na approved ng FDA and locally validated by RITM or the Department of Science and Technology ang gagamitin po natin. Next, please. So for the expanded testing also, we have included this different guide. No? Unang-una po, nilagay natin, only licensed medical doctors may be able to interpret these rapid antibody-based test kits. Ito po ay aming ipinapaalala sa lahat na kailangan po doktor ang nag-i-interpret nitong mga lumalabas na resulta dahil alam na po natin ang mga limitasyon nitong rapid antibody test. Kailangan din po mag-wear tayo ng appropriate PPE kapag ginagawa po ito. Hindi po pwede na wala tayong gamit na ito porque serology-based siya, hindi na tayo gagamit ng PPE. Kailangan pa rin na naka-PPE ang mag-a-administer nitong rapid antibody-based test kits. Kailangan din po mag-follow sa protocol ng DOH and that is what we have mentioned a while ago na ginagamit po natin ito. Unang-una, of course, for research, no? Yung mga seroprevalence studies natin. Pangalawa, maaring gamitin sa mga recovering patients for those for us to use as discharge criterion for quarantine, finishing 14 days quarantine, and also for those inpatients who are soon to be discharged, pwede rin gamitin. Pero inuulit ko po, hindi kailangan na maging basihan ng pagtetest para pauwi ng pasyente. May pinalabas na ho tayong protocol para dyan as long as physicians will clear that patients are already stable, clinically yung symptoms nag-subside na, yung ibang laboratories are okay na, maaari na pong pauwiin, mag-another 14 days sa bahay, at pagkatapos ng 14 days at saka itetest. And then the third, kinukuha rin po natin ng datos for this rapid antibody test. The results should be submitted to the Department of Health. So gusto ko lang ipaalam din sa lahat na gumagawa na po tayo ng return to work testing protocol. So everybody maybe has heard that a lot of businesses and different companies would like for their employees to be tested before going back to work. So the DOH, together with the other national agencies, are now drafting the return to work testing protocol so that all will be guided as to what will be used as the testing measure and also how can we use the rapid antibody test in this case where employees are being, the return to work for employees will be instituted already. Next, please. So that's the last of my slides. Thank you very much.
Thank you very much, Yusek Berhere, for guiding us and giving us these updates regarding the tests that the DOH advocates. For our second speaker, we would like to call on Dr. Edsel Salvania.
Good morning, everyone. So I'm actually just going to discuss more about the tests per se. Let me just share my screen here. Sir Nemi, can you see the slideshow?
Yes, I can see
Okay. All right. So really, this is I'm just going to focus on what the tests mean, and as Yusek Verheri has already shown, the expanded testing guidelines are there, our capacity. So I'm just going to say what they mean. I'm not going to say specific sensitivity and specificity numbers or even NTVs or PPVs because those, especially the NTV and PPV, will be population dependent. And Sensi Speci, particularly for rapid tests, is still variable and still needs validation. So, so for the currently available tests that we have in the Philippines, basically it's RT-PCR and antibody test. Antibody test in this particular case is a rapid test, but there are other formats which I'll discuss as well. So the RT-PCR stands for reverse transcription polymerase chain reaction. It's a test for nucleic acid. So SARS-CoV-2, which causes COVID-19, is an RNA virus. So that's why we need to do the reverse transcription before we do the PCR. So this is really the best test for acute disease, symptomatic disease. It does not distinguish between infectious virus or viable virus versus viral genetic material remnants. And this has really been cause for controversy because we have people who already cleared the virus and then become positive again. And we think those are just viral genetic remnants that are being mobilized from the lungs. As long as people are asymptomatic, RT-PCR is really not a very good test of cure. So it's very, very sensitive, but the type of the specimen can affect sensitivity. For instance, for nasal swabs, we know that it can only detect about 62% of patients who are positive. If you use a bronchoalveolar lavage, then that's about 93% sensitive. It's very specific because it's almost 100% specific, and really the only problem with having a false positive would probably be like contamination. So RT-PCR is currently the standard of diagnosis for SARS-CoV-2. It does require a BSL-2 facility that has already been mentioned, and it's a high level of technical skill and equipment. It's relatively expensive. The UPNIH test, the Gene Expert test, Sansure, these are all RT-PCRs. There are other nucleic acid formats, the Abbott Rapid test that we've heard about, which is not yet available locally. There are some isothermal tests that are being developed, but these are still being evaluated. So what's the advantage of having an RT-PCR? It is a standard for diagnosis. For now, WHO will not accept the case definition as a confirmed case unless you have an RT-PCR. It has the potential to pick up pre-symptomatic cases. These are people who don't have symptoms yet, but will develop symptoms in 2 to 3 days, although this is less sensitive than symptomatic because the viral loads may not be very high yet. So this is a known technology, and it's very, very specific, up to 100% specific unless you have contamination. The limitations are that it's expensive and resource intensive. And as we mentioned, if you use a nasal swab, 1/3 of them will test false negative, and these are symptomatic patients. If you use an oral swab, it's even worse. It's only about 32% sensitive. Again, it's a poor test of cure because viral genetic material can persist for a long time, up to several weeks. And that's why we're having these people test positive again. It is prone to contamination if you're not careful, and that's why the laboratory licensure processes are really important. And as you know, even our ITM had to shut down briefly because of contamination issues and people who were getting sick. So what does a positive RT-PCR test mean? So the first is, and you would hope that it really is a true positive. The second possibility is that there's contamination due to poor handling. Now, the third is an interesting one. You know, this is not a very big percentage, but because of the nature of RT-PCRs, you have to think about this. You might have inhaled virus, but you didn't inhale enough virus to cause disease. So you didn't get the correct amount of inoculum. And if you guys remember, there was a dog in Hong Kong that tested weekly positive. And this is a possibility. The dog didn't develop disease. So there will be people, and this is also part of the reason why you don't really want to test someone who just got exposed to someone with COVID-19, because they might actually have some virus in their nose, but it's not enough to cause disease, but they will test positive. And we think this is also the possibility that if these people tested positive, but they didn't have enough inoculum, they might not develop disease and they might not develop antibody. And so that's one possible explanation for people who tested positive but don't have an antibody response. Of course, there could be true no antibody response, but those are still being studied. And the last one is, again, what we're seeing with these patients who quote unquote relapse but really don't have any symptoms, residual non-infectious virus be mobilized to the nasopharynx from deeper components, particularly the lungs, in people who have already recovered. So what does a negative RT-PCR test mean? True negative, which is what we want, or it's too early, meaning you just swab somebody and they're still pre-symptomatic, so their viral load is low and it just didn't amplify. Or it's a poor inadequate specimen. Again, if we use nasal swabs, it's only positive 62% of the time. And of course, kit failure is always an issue, although the better labs will be able to detect it. So for the antibody test, there's three formats: the PRNT, the ELISA, ECLIA. There's even an EMCLIA, which uses magnetic beads. But those are all the same format in the ELISA thing. And then there's lateral flow assays, which is what the rapid tests are. So these tests can test for IgM, IgG, or both. But none of the rapid tests actually did very well when testing 7 days before the onset of symptoms. And so there's a high false negative rate if you don't wait until the body is able to make antibodies. And this is true for all these tests as well, PRNT, ELISA, although the ELISAs might turn positive earlier because they have a lower threshold of detection. So the PRNT is the gold standard. It tests for neutralizing antibody, which is what is considered protective, but this is technically demanding. You need to use it on live virus, and so you need a BSL-3 facility to do PRNT. So this is not a usual clinical test. It's used to validate the ELISAs, and in this case, ELISAs are lab-based, they're accurate, they're cheap, but you still need the lab-based. You just have to collect the blood and bring it to the laboratory. And finally is the rapid test, which is a point-of-care, cheap, unfortunately variable sensitivity and specificity. If you look at the FIND website, FIND is like a body that's affiliated with WHO. They've already started doing their validations. Most of the tests, actually all of the rapid tests did not perform well, less than 7 days at the time of symptoms. And then there's variable performance, but there were some locally available kits that did okay. I won't mention the brands. You can just look it up on FIND if you want, because we're still doing our local validation tests as well. Now, the advantages of antibody tests, it can detect infection even after the person has already recovered. So, you know, your RT-PCR will become negative after about 21 days, but the antibody will actually persist for several weeks. And then it's less resource intensive, it's quick results, and once validated, can be used to assess recovery, because as far as we know, when people have IgG already, they are not shedding viable virus. And this is based on limited experience right now, but it just makes a lot of biologic sense that once you have IgG, your virus should already have been neutralized. Once validated, can be used to assess recovery. And if with neutralizing antibody, which is still up in the air because we haven't used PRNT, that's the other problem. You can't use these current tests to gauge immunity because they may not be detecting neutralizing antibody, because they can detect pretty much any antibody that they're made against. The more important ones are the ones that actually neutralize virus, and this can really only be assessed with a PRNT or a test that is validated using a PRNT. The limitations of the antibody test, again, it doesn't perform well if it's less than 7 days. IgG does not necessarily mean immunity. Again, the issue here is neutralizing antibody. And it is prone to false positives in low-risk populations. What does this mean? According to Infectious Disease Society of America, if your population prevalence or risk is less than 5%, then even if you use something that's 96% sensitive, half of your IgM positives will actually be false positives. So you have to use a much higher stringent test for that, maybe 99% specificity. And so, sorry, that should read highly specific test, not highly sensitive test, although you still want it to be sensitive. So what does a positive antibody test mean? So you want it to be a true positive, but for IgM in particular, this is less specific than IgG. It's sticky. It can have a lot of cross-reaction because it's a pentamer. Now, IgG cross-reaction with other coronaviruses can happen, but the better tests that are very specific are much better at this. And there have been some very good rapid tests for specificity. Hopefully we pick those and not the bad ones. And of course, a defective kit is always a problem. So a negative antibody test is hopefully a true negative, but it can be also because you tested too early, and so the patient doesn't have a detectable antibody produced yet, or there's low titers or no immunity generated, and of course, kit failure is always a concern. So this is how we should understand the limits of the test. There is no good test for asymptomatic carriers. First of all, because if you're doing the rapid antibody test, they probably haven't had enough time to make antibody yet, especially the pre-symptomatic ones. For this, RT-PCR will pick up a subset of them, but it won't pick up everyone, and it's even going to be worse than the 62% because we know that the viral loads of asymptomatic carriers tend to be lower. So you may be able to screen some, but you can't rule out asymptomatic carriers with either an RT-PCR or a rapid antibody test. A rapid antibody test can capture people who have recently had disease that is missed by RT-PCR. And the priority, regardless of the test that you use, is to minimize the risk of transmission, because whatever you do, so first things first, you want to test, you want to screen out the symptomatics. If they're symptomatic, then test them with RT-PCR and isolate them. For the asymptomatic carriers, there's no good way to capture them. So what you have to do is minimize risk of transmission. So that still means social distancing, washing your hands, using universal masks, those kinds of things, because there is no way to completely get rid of the asymptomatic carriers because we don't have a good test for it. So this is kind of a busy slide, and this came out in JAMA recently. And you can see that there's different lines here. And you can see that for PCR, which is the blue line, it can become positive as early as 1 week before the onset of symptoms, but it's really best used just before or during the time that someone is symptomatic, at least for the first week, and then it starts to go down. Note that that doesn't mean 100% sensitivity. It depends, again, on the specimen, and it can be as low as 62% if you're using nasal swabs rather than bronchoalveolar lavage, which you can't really do much with. And if you look at the red line, and the red line is really important because this is virus isolation. And you can see that at the end of week 1, around day 8, 9, or 10, there is actually no more virus that you can isolate. In other words, the virus is already dead or non-infectious after day 10, even though the PCR continues to be positive all the way up to week 6. So this is the more important thing. This is why we say PCR is a really lousy test of cure, because the PCR can remain positive for a long time, even though the virus is no longer viable. So here's the thing: viral RNA shedding versus infectious virus. So then there's some data that indicates that viral RNA continues to shed after virus is no longer infectious. Actually, there's more and more data that says this. And again, the discharge criteria and discontinuation of isolation continue to be studied, especially after the cleared patients became positive again. And some people exposed to COVID, as we said, it can just be virus in their nose, but not enough to develop disease. Now I'm going to go back to that slide, and I want you to look at where the red arrow is pointing. Note that once the virus is no longer isolated as a culturable virus, that's when the antibody tests, which are the broken lines, become positive. So if your IgG is already positive, and that's the broken green line, chances are there is no more culturable virus there, even if the PCR is still positive. And that's around, if you look at week 3, because our current protocol is that we discharge them. You don't need to test them, but you can do an IgG after 14 days after discharge. And you can see usually the symptoms last 1 week in mild cases. And so by the time you're in week 3 and your IgG is positive, even if your RT-PCR, which is about a 50% chance of being positive still on day 21, you can see that if IgG is positive, then chances are you really are not shedding any more culturable virus or infectious virus. But again, this needs to be validated with more studies, because it's not very easy to culture virus, but it's actually a good biological, it makes good biological sense, but by the time you have IgG, you should no longer have infectious virus. So the best use for diagnosis, use RT-PCR for suspected COVID-19 with symptoms, and for highly exposed healthcare workers. Again, the antibody test is not very good for asymptomatics in general. The antibody tests are still being validated, but these are best used for clearing from quarantine 14 days post-discharge. IgG positive, I don't really care if they're IgM positive still with the IgG positive, because I'm going to go back a couple to the previous slide. You can see that the IgM, which is the purple broken line, can persist all the way to week 5. So even if it's IgM positive, IgG positive, I would think that they are already on the way to recovery, especially if they've been symptom-free for the last 14 days. And then diagnosing past disease can complement diagnosis as well. For serosurveys, I would rather use ELISAs. Of course, testing for convalescent serum donation. The other future tests that are coming are antigen tests, although they're technological hurdles and they might be less sensitive than PCR, but you don't need as complicated a machine and BSL-2, although that's still in the works. There's also been talk about using saliva as a specimen for nucleic acid testing. Seems to be better than the swabs, but this needs further validation. Imaging as well, aside from CT scan, maybe something else you can use to help. And then, of course, the isothermic testing, which requires minimal equipment. It's still nucleic acid, but it might also be less sensitive than RT-PCR. And so in summary, the RT-PCR and rapid antibody tests are two of the current technologies in the Philippines for testing COVID-19. Each has advantages and disadvantages, limitations. You still need to use your clinical judgment. This is why we have probables. Even if the test is negative and it looks like a COVID case, you still keep that diagnosis as a probable COVID-19. And tests are just to treat the patient, not the laboratory result, which I really don't have to reiterate because I'm talking to doctors who with the Philippine College of Physicians and the other societies, which really do this in our daily practice anyway. Thank you very much.
Thank you very much, Dr. Edsel Salvania, for enlightening us regarding the different tests that we are using. Very practical information, and I do hope a lot of those listening really will remember what you mentioned. Now we will have as our third speaker, our Director General of the Food and Drug Administration, Dr. Rolando Enrique Domingo.
Hi, can you hear me?
Yes, sir. Yes, sir. We can hear you, sir.
Updates on happening. We have approved by the FDA 30 test kits for RT-PCR. I think have about for antibody approved, and also we have the rapid antibody test, about 30 of them. However, done by our ITM, they're probably going to start by They're still ordering some of the reagents from overseas and together with staff from the did the approved test kits. Test kits that are approved now, validation done from the point of I think they have a sensitive maybe 80 to 90%. Lang specificity is a little high, 96% most of them. But what I think the important thing here is that we have to make sure that everybody understands what test they're doing and to choose properly. Not all the tests are the same. Antibody test kits, you cannot expect it that what it promises to give you 85% sensitivity to detect in the blood. And so we have to be very, very careful. I've seen the preliminary verification tests that were done by rapid test kits, and it very useful in this. We see that after the 15th day is after the start of early, lalo na yung 7 days symptoms, talagang is is going to be very, very if we're going to do it pulse or symptoms at all work, then we really have to be very, very all the negative tests we're going of confirmatory tests and that is why we made it a point that only request them and then interpret the results. And we hope that every doctor, before they decide on asking for a rapid test, that they study exactly what test they are using and to check what the sensitivity and specificity is. And then they have to decide when to use it on a patient and then interpret it very, very carefully. They also have to decide when they need to do testing again with an RT-PCR test. So you have to take all of this in consideration. When you buy a test, when you use a rapid test kit, you have to know exactly what it is. You have to understand what it is, and it cannot give you more than what the label promises.
Okay. Thank you very much, Dr. Domingo. Although your signal, sir, is not stable and choppy, but we understood the essence of what you wanted to tell us. Now we're going to entertain questions from those who have given their questions to us. And I would like to address some of these questions to our panelists. The first question is, do we have guidelines for COVID-19 testing on nursing home residents, particularly those who are asymptomatic? And a corollary question to that is, do we have guidelines for COVID testing for healthcare workers, those who are working in nursing homes and those who are going into these facilities?
Yes, sir. May I answer that question? Um, our guidelines for testing would be for the general population, and it should apply to specific situations and sectors. Like if we talk about nursing homes, if we talk about healthcare workers in nursing homes, the same rules or guidelines should apply to this kind of settings. Like we only test for those who are symptomatic, for those who are close contacts, and we do not uh, we only test for those at risk. So that is our general principle. So whatever setting or whatever situation, we still apply the general protocols of the Department of Health for testing.
Thank you very much, Yusek Berhere. We have one other question here. How do we estimate the actual number of cases of COVID-19 in our country, given that the data collected is uh, the actual cases given the fact that the given data that we collected are still limited? Do we use the case fatality rate of other countries? And if we do, what country should we be comparing it to?
Maybe Dr. Edsel can answer that for us.
Dr. Salvania, do you have any answer to this question? How to estimate the actual number of cases in our country, given that we only have limited testing that we're doing?
Right. So the question is, we know that about 80% of COVID-19 is mildly symptomatic. The asymptomatics that are true asymptomatics that will not develop any disease are not that huge. So we're still talking about the symptomatics in general. So if what our targets are A and B, and we're doing a good job with testing A and B, these are the patients who have symptoms who are either severe or critical, or moderate symptoms in the hospitals, then now that we have a positivity rate of about 10%, which is what 10% or less is what WHO wants us to be doing, what we're reflecting now is probably 20% of the caseload in the Philippines. So there's about another 80% who are mild, who hopefully are isolated. That's why we try to isolate people who are in the community. So you can estimate, and then depending on the percent positivity in terms of how well we're doing with our testing, you can probably add another 80% to the caseload for that. But because if you look at when we started, our positivity rate was about 20%, and that means that we probably weren't doing enough testing even among those patients who were severe and critical. But now that we're at 10%, it's probably better in terms of estimating the total number of cases. So there's two things in terms of how well we're doing with controlling COVID. One is the case doubling time, and again, because of increasing testing, medyo magugulo tayo dyan, kasi the more testing you do, of course, you'll pick up more patients. But if you look at the positivity going down with time, then that actually means that the increase is probably more likely because you're doing more testing. Because if the positivity rate is not is the same or going up, then actually as you get a bigger sample, that means that your cases are going up. So the fact that our cases have stayed around 200 to 300, whereas our positivity rate has gone from 20% down to 10%, that means that these increases that we're seeing is most likely a consequence of more testing rather than an uncontrolled epidemic. Meron pa rin, of course, but actually I think the increase is reflected because of the increased testing.
Thank you very much, Dr. Salvania. This question is directed to Dr. Domingo because, sir, the signal earlier was a bit choppy. The question is, any updates from the Food and Drug Administration on local validation of rapid antibody test kits? How is it being done, and what are our timelines?
Yeah, so I met with the last week, and the validation right now, the protocol is already. They have some reagents that they have to import, and they're supposed to be arriving this week. And hopefully by next week, they will start. However, this is not going to be a very. Have told me that they test about 300 samples per 4 to 6 weeks. Of the test kits 8 weeks before we get.
Thank you very much, Dr. Domingo. Sir, the signal isn't quite
Yeah,
yes, but yes, we were
Lemmy.
yes, yes, sir. We were able to listen to some of what you mentioned, Dr. Domingo. We will just be, of course, answering the other queries online by our by those who are attending the webinar right now. There's this other question, which I think is a very relevant question. Since these 2 months on quarantine, would it be beneficial to do mass rapid testing prior to return to the new normal? Since we're now preparing for the new normal, this particular question refers to that. Would it be useful to do mass rapid testing prior to returning to the new normal?
Dr. Edsel?
Yes, po, ma'am. So the problem with mass rapid testing, and I think so first of all, you can't do that with RT-PCR. It's just way too expensive. For rapid tests, the problem here is that if your prevalence is less than 5%, as the Infectious Disease Society of America has already mentioned, and the early indications with some pilot testing is that the prevalence with the IgM is only about 2 to 3% in select populations, and you use a test that is less than 99% specific, maybe a 96% specific, in addition to testing asymptomatics, which makes it even lower. If you have positives, the IgM positives, half of those will be false positives. And what will that do? That will make people panic. Second is you're going to use up a lot of RT-PCRs confirming those IgMs. And we know naman, based on the profile of tests, the biggest potential for transmission are people who are symptomatic. 80% of transmission is done by people who are symptomatic. So for return to work, the most important screening test is actually not a laboratory test. It's a symptom screen. Get fever, ask about fever or and respiratory symptoms in the last 14 days. And if you do that, you already get rid of 80% of possible sources of transmission. Now, the other 20% na potential transmitters are asymptomatic carriers or pre-symptomatic carriers. So for people who are asymptomatic carriers, as we mentioned, there's no good test for those. So kahit anong gawin mo, even if you test everybody, may makakalusot pa rin na asymptomatic carriers. So how do you preempt that? The most important engineering control there is still doing the social distancing, universal mask wearing, hand washing, disinfection. Because the rapid test kits will not solve that. In fact, if somebody is less than 7 days and not symptomatic, most likely it's going to be a false negative, even if they're carrying. So if you really wanted to look for asymptomatic carriers, the better test would be an RT-PCR. But even the RT-PCR will not capture all of those asymptomatic carriers. So you have to be really prepared na may makakalusot na asymptomatic carrier. And because the prevalence is very low, it's not cost effective even to test just a sample. But if they really want to, they can, pero cost lang nila. And it will not screen out all of the asymptomatic carriers. So the most important test at the start is really a symptom screen. And then everyone who is symptomatic needs to be tested with an RT-PCR. Everyone who is asymptomatic can be cleared for work, but you need to do daily symptom screens. And if they become symptomatic, then you have to isolate them.
Thank you very much, Dr. Salvania. I hope that is clear, no? That it is important for us that before we even return to work, that it is the symptoms that are most important and not really the test if you are asymptomatic. The next question is for Yusek Berhere. Our current positive cases reported by the DOH in their Facebook page is approximately 10,000. But why is it in this testing capacity result, the number is around 14,000?
Yes, sir. May I just, it would be better for me to answer this if I can have the date of that situational report that they got. But in any case, I will be checking on this, sir. What we give as as our reports daily in our situational reports, and whatever we report for a day is always the same with our sit reps. It might be that there might just be a day or so na lag dun po. No? Ito po ay kahapon namin na sit rep. Kung yung sa inyo po ay baka nung ibang araw na sit reps po. But I will check po so that we can provide you with a clearer information. Thank you for that.
Thank you very much, Yusek. This one is a question for Dr. Salvania. Will the gene expert result be considered a confirmed result, or does it need a confirmatory PCR testing?
It's an RT-PCR actually. It's a self-contained RT-PCR with extraction, and it reports it. So it should have the same sensitivity specificity as RT-PCR, and so it is considered a confirmatory test.
Okay, thank you for that. Next question is also for you, Dr. Salvania. Korea has mentioned that there are false positive results of RT-PCR tests among convalescent cases of COVID-19. They contend that these positive results are due to viral fragments and not due to live viruses. So is there is there no immunity after an infection?
So those are two separate things. So first, the becoming positive again, it's probably from viral remnants, genetic material. As we saw in the graph, culturable virus is not very common anymore after IgG shows up and IgM shows up, and also even if the RT-PCR remains positive. So that's one thing. Now for immunity, immunity is a much more difficult question because immunity here is being imputed with ELISAs and with rapid tests. And that does not necessarily mean it's neutralizing antibody. So that's why we need PRNT to look at this. There have been some PRNT tests done, and it does seem like that people do produce neutralizing antibody. But the question really is, does everyone do it? Does everyone make enough titers? And how long does it last? Does it only last a few months, or does it last for life? If we go with what happens with cold coronaviruses, it usually only lasts a few months. But hopefully with the vaccines, they target more conserved regions, and we know the virus is mutating, but if we target the conserved regions, then maybe there'll be long-lasting immunity, or we might have to vaccinate every year or something like that. We'll see. So a lot of that is still up in the air, but we know there's now more clarity about these relapses. As long as they don't have symptoms, we think it's just residual viral genetic material that is not infectious. And then we'll see more data on immunity in the next days, especially once we have validated ELISAs that are validated with PRNT, so we can better extrapolate neutralizing antibody levels.
Thank you very much, Dr. Salvania. For the benefit of Dr. Domingo, because the signal isn't good, allow me to read some of his answers to our queries. Dr. Domingo said, RITM will start validating the rapid test kits next week, and it will take about 6 to 8 weeks per kit. So complete validation will take about 2 months after the kits are submitted. At this time, I suggest doctors take a close look at the declared sensitivity and specificity of the kits before they use them. And also, Dr. Domingo adds, I saw preliminary validation tests of at least 2 rapid test kits done at RITM, and the sensitivity is higher after the second week of the onset of symptoms and much lower during the first week. So they might not be very helpful in asymptomatic people and patients in early disease. So this is consistent with what Dr. Salvania already mentioned to us during his talk. The next question is for Yusek Berhere. Are there guidelines for post-mortem testing of suspected cases?
There are no guidelines for post-mortem testing. I think Dr. Salvania can help us explain to all of you the virus and its status after the patient dies. Dr. Salvania?
Yes, ma'am. So, if you can get a sample right at the time the patient dies, theoretically, you might still be able to recover virus. But the problem is when somebody's dead and then the bacteria starts growing, bacteria produce RNases and DNases, so they can actually degrade the virus, and so it wouldn't be very, very accurate. If you can get consent to do testing from next of kin at the time that somebody dies and send that swab off in a decent amount of time, then you can probably still do that. But if it's somebody who's been dead a while, then the chances are even the virus is already degraded. It's not a very resilient virus. It decays after a few hours in the environment, and if it's in the body where there's already some bacterial overgrowth, it's not going to hang out for very long.
Thank you very much, Dr. Salbanya. Here is a very interesting question, which I know there are other colleagues of ours who would like to get the answer. What are your thoughts on RT-PCR for pre-operative clearance? Are there any guidelines or protocols on pre-operative testing for patients scheduled for elective surgery?
Yeah, so that's a real problem. Again, we don't have a good test for asymptomatic carriers. So if someone is symptomatic, then you can test them per usual protocol. But for asymptomatic carriers, you're going to miss some. So your best bet is still to treat everyone like they could potentially transmit, depending on the community risk. But in general, because it takes 24 to 48 hours to get your result back, if somebody needs urgent surgery, you can't wait that long. And if it's an elective surgery in general, again, you're not going to catch 20% of transmitters who are asymptomatic carriers. So from that standpoint, I would treat it just like the same thing. I would screen for symptoms, and if it's negative, then clear. But with the understanding that somebody can still be even if you do RT-PCR, kasi there's going to be a 24 to 48-hour delay, and you're still not sure if they really are just incubating the disease or not. So I don't think that you're going to be able to capture all of them. If patients want the test anyway, and if you can delay the surgery for 24 to 48 hours, that can be done, but it won't necessarily be paid for by PhilHealth unless they work out that, because we're still not at the level of testing where we can do asymptomatic patients. And again, the most important thing is it doesn't rule it out.
Thank you very much, Dr. Salbanya. There is this very interesting question. Is there a correlation between the degree of the disease and the amount of antibody being produced?
So that's still up in the air because a lot of the antibody tests, kasi it can go either way. I mean, if you're immunocompromised and you get severe disease, and you might not be able to make as much antibody. The second issue is we don't even know if that's neutralizing antibody. So the answer to that is the jury is out, because we know that people who have very severe disease, especially ARDS, may have like a secondary macrophage activating syndrome. So you could have more immune activation. We know their CRPs are higher, but its relationship to antibodies, you can try to extrapolate. But again, the issue of neutralizing antibody, degree of immunosuppression, there are just too many factors to make any conclusions at this time.
Thank you very much. This is another question from our viewers. What is the most common reason for invalid tests?
Maybe Yusek Rosette can answer that. I'm not sure. I mean, you could get an invalid result usually because your kit doesn't work, or you get equivocal things. But as to how often that happens, I'll defer to Yusek Rosette.
Yusek, would you like?
Yes, sir. We have about 100 plus of these invalid tests. There might be some issues in the processing of the samples, like when they transported, it was beyond the allotted time already, or the storage factor in local governments. So this would contribute to this invalid test.
Thank you very much, Yusek. This is a question from, I think, a physician who would like to ask this. The premise is that there are asymptomatic positive COVID patients. And premise number two is that doctors do see patients of unknown COVID status. So the question is, would it be a disservice to our patients if we continue to see patients without the doctor being tested just because he is asymptomatic and supposedly no exposure and run the risk of the said doctor transmitting the virus to the patient? So I guess the doctor who's asking this is concerned about the possibility of us, the doctors, being the carriers and infecting our patients.
Yeah, I think right now, and everyone's really scrambling because with this thought process that there is some asymptomatic spread, it's not huge. Again, symptomatic people are still responsible for 80% of the transmission. 20% may be from asymptomatic or pre-symptomatic carriers. Because if you're not sneezing or coughing, the risk of transmitting is not as high. But right now, basically, anyone in a place where there is sustained community transmission is a potential transmitter. It's not just the doctor, it's also the patient. So since we don't have good tests for these, testing for it won't be cost effective because you won't be able to rule it out unless you're symptomatic. So the most important thing to do is to protect yourself and protect your patient. So what does this mean? If you're in clinic, you wear your mask. If you are going to go within 3 feet of the patient or you're going to examine the patient, then you have to wear an N95, you have to wear a face shield, you have to wear a gown. It doesn't have to be a disposable gown, but you should change gowns between patients, gloves. So basically droplet precautions within 3 feet to minimize the risk of you giving it to the patient and the patient giving it to you. And the patient should also wear a mask. And then in between patients, you need to clean the surfaces that are usually handled. And at the very end of the day, you need to do the terminal cleaning. I know PSMID and FIX are going to come out with guidelines very soon to help this out. But, that is the real problem. We don't know who is an asymptomatic carrier, and everyone can potentially transmit.
Thank you very much, Dr. Salvania. Our time is almost up, but I guess I have one last question. A patient initially positive for RT-PCR has mild symptoms, but with subsequent 2 negative RT-PCR tests on the 14th and the 21st, and still tested negative for IgM and even negative for IgM on the 28th day. Is it still useful to repeat the antibody test to check for immunity? And when is the best time?
Yeah, so that's difficult, again, for the reasons that, we also talked about whether this patient just had an incidental positive and never really developed antibody versus a real infection and never really developed antibody. Right now, there's 2 ways to clear patients from quarantine. That's with the RT-PCR if they're no longer shedding. In this case, the patient can already be released. If you already have the RT-PCR negative, you don't necessarily need to show that the patient developed immunity or not. It could also be the test kit that was used might not be sensitive or specific enough. But basically, the 2 things that can be used to clear people after 14 days from discharge, from quarantine, from isolation, are a negative RT-PCR swab. And then if the IgG is positive, that helps you. If the IgG is negative, as long as your swab is negative, you can clear that patient.
Thank you very much for all our panelists for answering our questions. Unfortunately, our time is up. And we would like to thank, of course, our panelists for today, Yusek Maria Rosario Berjere, Dr. Edsel Maurice Salvania, and of course, Director General Rolando Enrique Domingo for shedding light into this very interesting discussion this morning. We still have a lot of other questions, and we will give these questions to our panelists so that they can be answered. Once again, we would like to invite everyone to tune in once again on Monday, May 11 at 10 a.m. for our 3rd webinar collaboration with the Department of Health and the Philippine College of Physicians with the topic Effective Ways to Handle Patients with COVID-19. So this has been your moderator for this morning, Dr. Nemesio Nicodemus Jr., saying stay safe and be healthy, everyone. Thank you very much.